Hello, welcome and kumusta. Thank you for joining me. This is How, your occupational therapist, and welcome to Occupational Therapy Conversation. In this episode, I'd like to give you some tips on how you can be better at doing some restorative interventions. When you're doing restorative interventions, you are thinking about restoring performance components. You could be doing some restorative interventions, particularly on getting a person to be independent, back in doing the things that they were doing with their personal care or with their ADLs or with their leisure activities. So it's quite simple. When you're doing some restorative intervention with ADLs, particularly, all you need to do is just do it. You need to just practice and get cracking. That's straightforward, especially if the person was just deconditioned. So all you need to do is just get cracking, just do it. But sometimes it's not that simple. And one major tip that I would like to share with you when you're dealing with these restorative intervention is you need to be aware of the developmental processes, the developmental stage, or the sequence of the task from simple to the most complex part. That's why I would always say that working in pediatrics would be such a beneficial experience for any clinician because you get to see the skills development from when the person or when the child is learning it all the way to when they're actually grown up. For example, dressing now. This is personal care, ADLs. So in terms of putting on clothes, for example, what is the simplest task when somebody is putting on their clothes? So you have to imagine, try and go back to that time where you've had an experience of trying to put clothes on a child, or maybe yourself as a child, or maybe you've worked with somebody, a younger niece or a nephew or a cousin. If you've worked on that, what happens? Are they able to put on their clothes straight away? Not yet, isn't it? So what they tend to do is you give them the clothes. You don't just hand over a shirt to the child. You work with them. You sometimes identify colors. You identify parts of the clothes, where the head goes to, where the arm goes to. But usually when you're doing that, you are just letting, if you're helping a person put on their clothes, particularly a child, you just give the clothes, you hold the clothes, you prepare the hole where the arm is going to go through, and then you just let the child stretch their arms out. So that arm stretching on its own is a skill, and it is a task, and it is something that the person will need to do. So if you're working in a hospital setting and they cannot do it, just let them do it first. Just let them stretch their arms first so that a clinician, yourself, or a therapist, or a healthcare support worker can then put on the clothes and don it on their arms. That's one way. Or you put it over the head and then the person will just pull it down from the head all the way to pull it down towards their head. And then the child will be able to perhaps lean forward and adjust the clothing by pulling it from the upper torso to aligning and arranging the clothes. So that's one way of doing and thinking of the task and of the skill. In taking it off, it's pretty much the same. The most simplest task is by pulling. It's the end part of the task where the person will just have to pull the clothes off their hands and their arms, actual doffing of their arms. Or you could get a person to just pull it off their head and pull it overhead. So those are some of the tasks that you need to do. And if you analyze and you break down those skills, then those every little skill can be a therapeutic session. You can use those as a guide in terms of what enabling activity that you can be doing with a person. So you can even have enabling activity where you can just practice the person donning and doffing or putting things up their arms, for example. So that's some session that you can do. Multiple rubber bands, put it around the hand, because it entails a lot of attention, it entails a lot of concentration. And if the endurance is very bad, I'm telling you, just the task of putting it on or even concentrating on the session, just the task of that alone is going to be very difficult for the person. And if that is difficult and you're doing something about it and you're doing some sessions, then you are doing your session, you are doing your restorative activity. And this is particular to dressing. So, some restorative activity would, say, for example, combing or brushing the hair. So, break those tasks down. So, if you give the comb over and put it on top of a table, for example, you set it up for the patient, and if they can't do it, what does it entail? You have to think about this as a clinician. What does it entail for a person to be able to comb their hair? First, they need to know the task. Second, they need to look at the comb. Third, they need to reach for that comb. Fourth, they need to be able to reposition that comb. Fifth, position it properly in the hand. Sixth, you need to be able to stroke the hair, reach the arm towards the head, and then seven, stroking it on just one, and then the other part, and then moving the arm enough so that the person can tolerate and reach different parts of the head. And this involves varying degree of upper limb movement. This involves varying degree of range of motion, and this will challenge the person's endurance, muscular endurance. It will challenge the person's fatigue. When a person normally combs their hair, they're not normally in bed, aren't they? Or if they're on the chair, they don't normally just lean back and comb their hair. Normally, there is a certain postural control that the person needed to do. They need to lean forward and get that endurance going. And then the person will have to do it to a degree that they can actually perform the task to a degree that they're happy with. So now you can just break down those tasks and then think of some enabling activities that would simulate those things. So, how can you do that? You can do hand manipulation of an object, turning it left and right, putting it from one hand to another. Say, having a comb, simulating a comb or a pen. You can put a pen in hand and then you can just turn it, move it in different positions in the hand. So that's dexterity session. You can get a person to doing something that is overhead that involves reaching and grasping, and that involves reaching different parts of the body. So these are some of the sessions that you can think about in preparation for your enabling activities. If they cannot go directly to doing that personal care. Again, this is now, if you remember, stages of rehab, the continuum of rehab, this is now enabling activities, which is a step down of the purposeful activity, which is a step down of direct ADL retraining. So there is a room for therapists to do the session, even if the person is not medically fit, even if the person is not medically optimized. Say, for example, you read the notes that they're up for a CT scan. That's not a bad thing, isn't it? They're just up for a CT scan. That should not change a person's ability to do their combing or their top half dressing, or things that they can do and participate, or tabletop activities. These are some sessions that you can do. What about bottom half clothing? This becomes more tricky because it demands more physical challenges. So it demands more physical challenges. Is that the way to say it? There is more physical challenges to it. That means a person should have the ability to lean forward and back and scoot forward. You can practice crossing the legs over left and right, move left and right. And if they can't do that, do it over and over again. Cross the legs left and right, left and right. Do it 5 times. Do some sessions on those things. Why is that? And if they can't do it, and why do you need to do it? Because you're building up activity tolerance. little activities that you need to do over and over again. So that is on the bottom half dressing, leaning forward to reach for that leg, for that foot, to be able to don things, to don an item on the legs. Wow. So that is more. And you need more gross motor retraining when you're doing this with your bottom half dressing. What about putting on the shoes? You need to be able to move the foot and locate and place the distal part, which is the foot, so that you can actually put it on top or onto the shoes. Cross the legs over, lean to pull the back part of the shoe so that you can actually don it. Socks is another thing. You need to be able to use your hands by putting it into the opening of the socks. Then you have to have that strength enough to be able to move it. It's just like a rubber band that you're moving around. So you need to be able to manipulate these things. And you need to be fast enough so that whenever the clothing item, which is the fabric, whenever the fabric is moving, you need to be able to adjust on how it's actually moving, and then you need to be able to adapt to it, catch it, manipulate it. So those are some of the basic things that you need to do, and these are all enabling activities. So learn the stages, know the stages, and then you can break those stages and have an enabling activity that is focused on those stages, so that you can have your session even though it's not a direct ADL retraining. Again, there is no reason why we cannot do our sessions. If you look at the even if you look at the notes, even if they are reported to be functionally not well, yeah, you can have multiple sessions. You can have a lot of sessions despite the person not medically unwell. Obviously, if they're in the middle of having a heart attack, then you can't do that because that's a medical emergency. But as soon as that's settled, you can have sessions with a person straight away. So you ask what kind of sessions you can have for somebody who's had a heart attack. I mean, you can start talking to them, supportive conversation, tap onto that spirituality and volition. They might be anxious, so they probably don't know what's happening. You can start educating them about what's happening. That's another session. Now, in terms of the restorative sessions focused on performance components, then you need to know the sequence of development or the stages and the grading. For example, for strength, you have the Oxford scale, 5, 4, 3, 2, 1, and 0. That would be the grading system in terms of muscle movement. And when you do that, then you can have your session sequentially. So, for example, if the person has a muscle grade of 0, then you need to facilitate that. How are you going to facilitate the muscle? You use some techniques such as proprioceptive stimulation. How do you do proprioceptive stimulation? So you squeeze the muscle bulk, you stimulate the muscle spindle, you do some muscular stretching. How do you do the muscular stretching? That's through quick stretches of the joint. Proprioceptive stimulation, Golgi tendon organ. These are all movement of the muscles. And if the person's not working or doing it yet, you may need to supplement that by you as therapist manually holding onto the muscles. And that's why occupational therapists or physiotherapists or therapists in general would be perceived as somebody that's giving a massage, which is not a bad thing. Giving a massage, for those of you who do not know, is a tool of the trade. This is tools of practice, not for occupational therapists in general per se, but obviously we can borrow it since we can do what physios are doing. This is a tool of the trade of the physiotherapist. It's massage, therapeutic exercises, use of physical agent and modalities such as temperature, such as electricity or electric nerve stimulation, ultrasound. These are all physical agent and modalities. So you can do that and you'll have to stimulate that. What if the person now develops a muscle strength of 2. So there's some movement. So if there is a movement, then what you need to do is again similar to proprioceptive facilitation, some PNF techniques like repeated contractions. You can do that. You can do quick stretches. You can do repeated contraction on its own. Isn't it? The more you contract those individual muscles, the more it will move. That's that. And if they're fair, muscle grade fair, meaning they can move against gravity, then just do something that will involve that. But it's quite boring if you just repeat the muscles like left and right, push and pull, straight and bend, tug and pull. It becomes so boring, isn't it? And that's why most of the sessions, if you take note of what's happening with the sessions with physios and you observe, and even yourselves as occupational therapists, you can see that the session is just maybe 10 minutes because it's boring. Even yourself as therapist gets bored. What you need to do is put it into something, like put a music into it and then move through the rhythm, move to the beat, exercise every song, first song, finish a song. It's almost like an aerobic exercise or calisthenics or a workout. That way you lose count of the number because the number doesn't matter. What matters is the consistent ability to move the elbows, the arms, the legs without needing to count. Because when you're doing things functionally, you do not count, you just do it. Or you do it over a period of time. But even time is something that you don't count normally. The ideal thing is for you to be able to move without needing to count. For a person to be able to move and use their body to do the things that they needed to do without having to worry of counting. You don't count 10 steps, that's it. I'm good. You count that you're able to get from wherever you want to go to. So that's strength, for example. That's in general strength. What about the dexterity or the prehension pattern? What are the stages for that? So you're thinking about that too? What is involved with prehension pattern? Person will need to be able to look at an item and place the hand, anticipate, reach for the item, open the hand opening, lifting off the wrist, and then placing the hand onto the item, making a grasp, lifting it, carrying it, performing a certain grasp, and then moving it to the place where they wanted to take the item, right? Those are the stages. So when you look at the hand, what are the sequence of prehension pattern, the gross prehension pattern? Starts with a hook grasp. Just imagine a child, for example, doing a hook grasp. Everything that they carry, they're just bending their fingers. So that involves just the flexion of the proximal and middle phalanx, like a hook, like a monkey's hook, like when you're carrying a shopping bag with your fingers, scraping things. That's the first step. Hook grasp is the first one. The next one that would come back would be a cylindrical grasp, where now you are carrying or holding on to a pole, holding on to this walker, for example. That's a cylindrical grasp, but only it's a bit smaller. Okay. And then the next would be a spherical grasp. So that's more complex at the moment because it involves flexion of the IP joints, flexion of the fingers, abduction of the fingers as well. And it's the fingers, so you have an individual hold on an item. So by knowing these stages, you should be able to come up with the treatment plan, the enabling activities that you needed to do. What about getting out of bed? The simple task of getting out of bed. What's involved? Rolling. So how does rolling start? It starts with the head control. So a person moving the head first, then followed by the body. Lie on the side, push sideways to sit down on the edge of the bed. Okay, there you go. And then you're upright. Then maintaining that sitting balance and tolerance that person is not swimmy. When the person is swimmy, so it's not necessarily the trunk that is a problem. When they're swimmy, something is either wrong with their vestibular subsystem or their cardiorespiratory reserve is not so good that when the body is upright, the heart will have to pump in a little bit more harder. And when it pumps in harder, That means blood is not flowing as normally to the head, and then the person will feel tired, will feel a little bit swimmy. So that's just sitting alone. Then you can just simulate those activities. Rolling in bed is a session, rolling from left to right, leaning to reach onto those bed rails. You can position the person in supine. The task would be to roll on to the left, go back in supine, roll on to the right, get the person to reach towards the edge of the bed, towards a cot side or a bed rail. Try moving some items. So put items in front of the patient if they're side lying, put an item onto their like frontal side, and then get them to reach for it using their hand and then moving it behind them. How's that? That's one session. What about having a session where a person is just holding onto a piece of an item, for example, like a ball or something soft, something that won't hurt them, a squeeze ball, for example, and getting these squeeze ball, if they're lying down, behind them, reaching behind them, and then trying to pass it on so that they can pelvic bridge and then reach it to the other side of the hand. That's a little bit difficult to do. What about when they're lying down? What about bending the hip? Bending the hip so that they can reach for their knee or they can reach for their toe. That's essential when you have to help somebody get dressed. That skill of moving. So that's physical. What about eating? What are the stages of eating? What's the simplest way to eat? A child would have, there is a reflexive way on how children would eat, and this is suck reflex, fruiting reflex. But normally, a person's hand, pretend that they're holding a bottle, a milk bottle. So a person need to be able to put the hand in midline to hold it in such a way that they can hold the bottle. So it's the same for when people are grown up. So if they're so weak, then that's the first session that you need to do for them to be able to move the hands so that it can approximate things in front of them and they can position themselves. So even holding a ball in front of them when they're lying down is a session. Pass it on, straight the hand, bring it over, bring it to their chin, bring it to their belly, bring it to their chin. Yeah. And then an adaptive way of doing that is moving it from left to right. So there is you're involving a spherical grasp in there. Put it on the side of the bed. Just let them find the item on the left side of the bed, by trying to get that sense of, by feeling by hand. And it's called stereognosis. Try to fumble their way around until they can find an item, with their right hand if they're lying down, move it across their body, then move it onto the left side, transfer it to the left side, and equally do that in reverse. So this is like crossing the midline activity. And when a person is doing crossing the midline, it stimulates their both sides of the brain. See how wonderful those things are? It's amazing, isn't it? So with eating, they need to have a look at an item. They need to direct, pay attention. They need to do that. They need their body to be straight and at least be in anticipation of that food. They need to have that amount of grasp so that they can utilize the cutlery. If not, then it's finger food. You have to bring it down a step level down, a notch down. Finger food. Picking items using tripod. Again, with fine prehension, what are the stages? Lateral pinch comes in. That's 7 months. Tripod, or 3-jaw chuck, it's called. That's 7 months. Pad to pad, pad of the thumb and pad of a finger, like usually it's the index finger. That's 10 months. And then tip to tip, or you would call it a pincer grasp. That would have been 12 months. So you see, those are the stages that you need to follow. Okay, right. So in conclusion, if you need help or if you want more tips or you want to improve on doing your restorative sessions and restorative activities, you need to, one, remember how to break down those tasks that the person needed to do, find out those aspects that the person can't do, and then think of activities that would simulate those activities or those tasks. And that is called enabling activities. So you need to be able to break those things down. You can do that. You're an occupational therapist. Activity analysis is a part of the tool of your trade. That's one. Another technique on how to do that is by learning or reviewing and revisiting the developmental stages of movement, from lying to rolling on the side, going on prone, leaning on elbows, going on all fours, crawling or lying, sitting down, and then sit, lean forward, stand up. Okay. And when you're standing up, you're walking with an astride gait, and then heel strike comes in, more refined movement, walking with narrower base of support. Okay, so those are the stages. So when it comes to eating, for example, it's the same, having a look at things, reaching for it, putting things in the mouth, hand to mouth approximation. As kids, hand to mouth approximation, and as children, these are all very reflexive. These are all programmed in the mind already. So if a grown up can't do that, that means that the person is limited by general strength, in which case you just need to build up their condition and their strength. Again, going through those stages and thinking about your sessions. All right. Well, I hope you learned a little something today, guys. Just remember, anything you do matters and has an outcome. I hope you be a better therapist. Okay, until next time, bye. If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. I am but your humble clinician, albeit with years of experience, I have very little understanding of this digital world. So if you have any questions or if you have topics that you want me to talk about, drop me an email. It's riot.conversations@gmail.com. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.